So AVAC is an organization based in New York but working globally on advocacy to do two things really: to improve the prevention options, to get them developed through strategic R&D activities and advocacy to support R&D, and just as importantly to be sure that new interventions are actually deployed. Not just enough to develop them, but we have to make sure they get delivered. Prevention is always tricky. In the current landscape, sitting in 2014, where people have for the last 2 or 3 years begun to talk about ending the AIDS epidemic, and there's a lot of euphoria there, and it's important because we have incredible science around antiretroviral treatment and using that treatment as prevention. 5 years ago, we had the first evidence that voluntary medical male circumcision could also provide benefits. We have this growing panoply of prevention options, and they can certainly help to bend the curve of the epidemic. So when you work in communities, as we do at AVAC, in Africa, Asia, Latin America, and the United States and Europe, communities know what they can have today. And we need to make sure that that gets delivered to scale. But we also need to recognize that the long-term strategy has to include research and development. We're only at this precipice to end the epidemic because science got us here, but we need to make sure we focus not only on the science of delivery, but still the science of developing the additional tools which are going to be essential to truly ending the epidemic. Well, it's interesting, in each intervention where you think you have great science that tells you treatment as prevention works, voluntary medical male circumcision works, the HPV vaccine works, in each of those areas there are people who say it doesn't, or reasons why it's not feasible, each in their own way. So you have campaigns in every area that says why something isn't possible. And in the HIV space, we see people who say, we can't provide condoms to young people because it's going to increase promiscuity, or we shouldn't be delivering the HPV vaccine because it would also increase young women and young men wanting to have sex. These are absurd arguments, but ones that are made time and time again. So I think we constantly see it. I think we are getting better, though, at overcoming it. So just 2 years ago, in the US, the Food and Drug Administration approved for the first time the use of an antiretroviral drug for prevention as well as for therapy, so-called oral PrEP. And we saw many of the same exact concerns. If we give people a pill, they'll act irresponsibly. But in fact, we now have really good evidence that scaling up circumcision programs, that providing HPV vaccines, that providing oral PrEP doesn't at all increase promiscuity, doesn't increase one's risk. It actually does provide longer-term benefit. So we have evidence, and I think what we need to be doing is less worrying about cynics each time and responding to each of their claims, but rather making sure we have the clear evidence, because we do, but making sure we're communicating that evidence particularly to policymakers and to communities, and ensuring that they're part of that conversation from the beginning of the research process all the way through to the delivery. And as we do that, I think we're beginning to build a community that does understand science, that understands evidence, and is willing to fight for what needs to be done in public health.